Hello friends, I am Dr. Deepak Garg. I am an orthopedic oncologist and today we will discuss subungual exostosis. So these are benign cartilaginous tumor. So they usually occur in patients with a young age group. Usually more than 50% of the patient have age less than 18 years and they usually will present in the distal phalanx. So distal phalanx is a hallmark and 80% of the patient will have distal phalanx of the big toe and rest 20% of the patient will have distal phalanx of the other toes. And when the patient will present to the OPD, patient will present with the pain in the nail bed or swelling in the nail bed. There can be nail plate deformity, ulceration, or sometimes there may be infection. Patient usually will have a history of months to years when he will present to the OPD. So if we look at the plain radiograph will show a small bony protuberance. We can see here this is a small bony protuberance attached to the dorsum or side of the distal phalanx of the bone, and there is no continuity between the lesion medullary cavity and the parent bone medullary cavity. There is no continuity. So this is a plain radiograph finding. The MRI may or may not have small cartilage cap. If the MRI has cartilage cap, sometimes it will be T2 hyperintense. If we look at the etiology of the disease, many patients relate it with the trauma and infection, but the causal relationship is uncertain. But the real etiology is cytogenetics, the translocation of X and 6 chromosome. So this segment from the X chromosome is translocated to this segment at chromosome number 6. We can see here this is chromosome number 6 and this is chromosome number X. So the translocation happens between the two chromosomes and this leads to the tumor. If we look at the histology, it is composed of the fibrocartilaginous tissue. If we look at the periphery of the lesion and the stalk, the periphery is composed of the fibrocartilage and the stalk is made up of the bony trabeculae. So this is a histology. Cartilage cells may look atypical and hypercellular, and there can be nuclear enlargement. It can blend with the spindle cell proliferation in the nail bed. Mitosis can be present, and the cartilage cap, if present, can be tenuous or usually absent. And if you look at the bone formation, the bone forms through the endochondral ossification. So because it's a cartilaginous tumor, so the cartilage is forming and then over the cartilage bone is forming. Or sometimes it is seen that the bone may directly form from the spindle cells. And we have already seen the genetic analysis. So this translocation that has occurred, it will lead to the overexpression of the IRS4 gene, and this lead to increased mRNA proteins and ultimately will lead to the subungual exostosis. Why this gene is overexpressed? Because the breakpoints are located in chromosome number 6. It is located in the col 1 to A1, and in chromosome number X it is located near the IRS4 gene. So when the translocation happens, this gene get activated and start producing high amount of mRNA. So the treatment is very simple. Treatment is a simple excision of the exostosis, and usually the patient will not recur, and if the recurrence happens, the treatment is again the re-excision. If we look at the follow-up, initially we follow up the patient 3 monthly, and gradually we start following at increased interval like 6 months and then annually, and after 5 years we do not usually follow the patients if there is no problem. So this was all about subungual exostosis. These are the references that we have used. Thank you guys, thank you very much.